CT scan and MRI, because they're both pretty similar in congenital heart disease. So we'll focus on CT, and most of the indications of CT are the same as for MRI. But before I start, one word of caution is that CT does carry a risk of radiation, especially in the pediatric population. And so it's important to use it only when necessary. And therefore, today the points we'll go over about when is it necessary is extremely important, because we see today with the availability of scanners, especially 64 slice scanners, now 128-bit scanners, we see a lot of CTs being done which are not really indicated at that time. So let's go over what most of congenital heart disease, echo is really the best. And echo gives you the best diagnosis for most of the intracardiac anatomy. Anyone would like to say what are the structures of the heart where echo is not the greatest, where you may want to think of CT? The structures of the heart. We're not getting into diseases, but what structures? Like, think of arteries, think of veins. Anyone would like to answer? Which structures of the heart where echo is not the best? Yeah, bundles is true. That's more from an EP. I mean more from a anatomy perspective. From a anatomical, like an artery or a vein or a chamber. So which structures do you think of the heart? Echo is not always the best. Cannot visualize it. When nodes, you mean like so you mean like for ECG, which would pick up. But let's think of anatomy. Think of pulmonary artery, think of aorta, think of aortic valve. Which structure would you think I want to get a CT scan for? Because I don't think my echo may be able to show me very well. And there are a couple of structures. One is distal pulmonary arteries. So if you think about it, the heart is in the middle of the thing. So that's where we do our echo. But when we have the pulmonary artery, which is going into the lung, that the echo cannot always see very well. The first part of the pulmonary artery, yes, it can see. But when you go deep into the lung, distal pulmonary artery is not seen very well. Tricuspid valve would be seen very well on echo. You can see tricuspid valve, mitral valve, aortic valve, pulmonary valve, interventricular septum, interatrial septum, all this very well on echo. Pulmonary veins is another area. Sometimes there is confusion where the veins come in, because again, now this is behind the heart. If you think the heart is here, the veins lie posterior, they are behind the heart. Sometimes we don't see it well because you're echoing from here. The veins are right at the back. So pulmonary veins sometimes is an issue. Collaterals. And the fourth is sometimes the aortic arch, the distal part of the aorta. You can see this part. See, when you do a suprasternal on echo, we can see the arch. But sometimes the part which is going down deep into descending aorta is harder to see. So these are the structures where echo, you may not get all the information you need. And therefore, this is where you start thinking of additional imaging or some additional test. Now, let us say a cardiologist is not able to see the pulmonary veins or the distal pulmonary arteries or the arch. What was the choice before? The choice was cardiac cath. So these babies used to go to the cardiac cath lab, but there's a risk of complications, especially if it's a sick baby, a very cyanotic baby, very small baby, like a 3-kilo baby. You do have a risk of complications. And that's how CT and MRI evolved as a diagnostic choice when you need a second decision making. So let's go over some of these things that are looked at on CT. So pulmonary arteries. Now, if you look here, a lot of studies have been done looking at the pulmonary arteries on CT and correlating them with the pulmonary artery anatomy on cath and surgery and echo. And in the past, and when I say past, even up to 5-7 years ago, in India, everyone was doing cardiac cath to look at the pulmonary arteries for instance, in tetralogy of Fallot. So in tetralogy of Fallot, you have a blue baby. If the pulmonary arteries are very small, you may not be able to do the total correction. You may have to do a BT shunt. So you need to see the pulmonary artery size. So we see on echo. Now, if you can't see on echo, they used to go for cath. Now, if you can't make out clearly the pulmonary arteries on echo, they can go for a CT or an MRI. And then, as we discussed in a previous class about tetralogy, you need to know the coronary arteries. Again, if heart rate is slow, you can see the coronary arteries on CT as well. So look at this CT, right? RPA, LPA, I've labeled it for you. It's so easy, right, to make out the size, the anatomy, and even distally into the lungs. Now, let me show you another CT. This one is not looking so high fly. It's your typical grayscale that you'll see. What can you tell me about the pulmonary arteries in this CT? Anyone? Do you see the pulmonary arteries? Are they normal? Are they small? Can you see the pulmonary arteries? For some reason, the chat box keeps disappearing. I'm trying to get the laser pointer working. So if you can see here, and let me see if I can get this laser pointer working on this. Where's the laser pointer gone? Annotate. If you can see here, and I want you to see this because you'll see that it's very easy actually to actually report a CT. And so it's important that, everyone starts looking at their CTs. Yes, so if you see here, this is the left pulmonary artery, this one. This is the right pulmonary artery. So you see, and they're both small. So these are small, that's right, these are small pulmonary arteries. So on CT, you're able to, let us say on echo, we weren't able to diagnose what was going on. On CT now, you're able to diagnose that this baby has a small pulmonary artery and we need to do a BT shunt rather than do a complete correction. So let me close this annotation tool. Okay. So this are what are called hypoplastic PAs. Now let's look at this one. This is again the CT. What do you see here where the arrow is? You see where that arrow is? What do you think that is? That's a stenosis. You can see a narrowing there, right? So you see in this, when you look at it, and let me annotate it again here for you. When you look at it here, this is actually your right PA. This is the beginning of your LPA. This is a narrowing in there. And this is what we call post-stenotic. The pulmonary artery's gotten bigger beyond it. So very clearly on CT scan, you're able to look at the pulmonary artery anatomy. Now, in a normal patient I shouldn't say anyone with tetralogy is normal, but in a patient with tetralogy where your pulmonary arteries are good sized, you're able to see them, you don't need all this. But in a patient where they're looking very small or they look to you like there's a blockage, then CT scan gives you such a very clear anatomy that you don't all you need a radiologist or a cardiologist or even a 12th standard person can look at it and say, hey, it's narrow there, because the anatomy is so clear. And this, especially with now what is happening with 3D, you can really see everything. So now you look at this one again. What do you see here? This is one pulmonary artery. And this is one. So you can see that they are good size. Yes, this one's dilated, right? This right side one. And the left one is smaller, but the right is dilated, right? So, these are definitely good sized pulmonary arteries. So even though the left is smaller, they're both good sized, and you can definitely do total correction with this. So it's very easy, as you can see. Sometimes in echo we are struggling to see especially when they're small. When they're big like this, echo is no problem at all. Now let's look at this one. So look at the pulmonary arteries here. They're very dilated. You see them, right? Similar to the last case. So which cardiac diagnosis do you get dilated pulmonary arteries in? Which disease? Anyone? I'm not sure we have covered it yet. Which disease do you get? In Epstein's, you're going to get a dilated right atrium, right ventricle. You're going to get a dilated right atrium. But which disease has huge pulmonary arteries? So in tetralogy of Fallot, there's pulmonary stenosis, they are blue, they have small pulmonary arteries. In one tetralogy, they have huge pulmonary arteries. And this is it's a small subset of patients where the pulmonary arteries are huge, and those pulmonary arteries actually compress on the bronchus. Because if you think about it, your pulmonary arteries lie here. Behind them is the bronchus, right? So if you get hugely dilated pulmonary arteries, they can compress on the bronchus and cause the baby to have wheezing, respiratory symptoms. Even if it's on the trachea, they can be having stridor. So if you look at this, these are huge pulmonary arteries. And if you look here, this is the right lung, this is the left lung, right, on the other side. And you look here, you see the bronchus. Do you see the bronchus, the airway down here? I'm trying to annotate that. Let me see if I can annotate that. But you can see that one side of the bronchus there's no air at all to the left. Look at that on the left. So this is called tet absent valve. So tet absent valve has very dilated pulmonary arteries, and these pulmonary arteries compress on the bronchus. So you see here, there is no air going. I don't know why it's not annotated. Okay, this. You see this versus this. You see how there's air there in the bronchus, and you see here on the left side it's a little sliver. So this is again where CT scans can play a role. In tet absent valve, the pulmonary arteries are huge. You put your echo probe, you are seeing only pulmonary arteries. You don't need a CT scan to look at the pulmonary arteries. But what you're looking at is what are they doing to the airways below. So in tet absent valve is a lesion where you have a VSD, you have a pulmonary valve which is obstructive, and you have flow going and coming. Pulmonary stenosis, pulmonary regurgitation. Pulmonary arteries get very dilated. Those pulmonary arteries will compress on the bronchus. That causes the baby to have stridor and respiratory issues. And before you operate, you want to know where is the bronchus compressed, because part of the operation is pulling the pulmonary artery off the bronchus and relieving that bronchial compression. And this is where CT scan can play a role, where you're looking at the effect. Now, this is something on echo you can't see, right? On echo, we can't really see the bronchi. So you're looking at the effect of the pulmonary arteries on that bronchus. Okay, let's move to another lesion. This is a 3-dimension. Now, if you look at this, what has happened with imaging in cardiac disease, which is why now, adult cardiologists love CT, pediatricians love CT, because when you get a 3-dimension, you can see everything. So this is the arch of aorta, right? What we learned in our anatomy in medical school. Now, what do you see here? Anyone? So this is the arch, right? This is the arch. You can see it beautifully. There's no narrowing, right? So this is not a coarctation. This is the innominate artery. This is the left carotid. This is the left subclavian, right? This is ascending aorta. This is transverse arch. This is your descending aorta, right? But you're seeing all these extra things coming off. You see all this? You see all these things coming off. This, Now you do get spinal arteries, right? You get intercostal arteries, but those generally come off like this in a straight way. So what could this be? What comes off the aorta and goes into the lung? So this is what is called collaterals. So if you look here, these are all collaterals. Now where do we see collaterals? So collaterals is nothing but blood coming from the aorta going into the lung to supply the lung. So when are we going to see collaterals? When, for whatever reason, there's not enough blood in the lung. So this could be like, for instance, a pulmonary atresia, a severe tetralogy. Could be any lesion where there's less blood to the lung from the heart. And we are all, for instance, we are all survivors, right? We have a problem in our life, we find a solution. It's the same for the lungs. You don't give them oxygen from the right ventricle, they will figure out a way to get blood and oxygen from somewhere else. And this is God's way of giving those lungs blood and oxygen. So if the right ventricle, for some reason, is unable to give blood to the lungs because of severe pulmonary stenosis, pulmonary atresia, then the aorta will give off these blood vessels to the lungs, which give blood and oxygen to the lungs. And that's how these babies survive. So for instance, if you have a baby with pulmonary atresia, there is no blood going to the lungs. The baby is 3 years old, walks into your OPD with pulmonary atresia. Blue, okay, but has survived. How have they survived? Either they have a PDA or they have all these kinds of collaterals. Now, when we do an echo, we can see that, okay, there's the aorta, we see its pulmonary atresia, we see the aorta, and we see some flow coming off, from the aorta. So we know there are collaterals, but we cannot define the collaterals like this. So in a case of pulmonary atresia VSD or any pulmonary atresia, when you're deciding, okay, I have to operate, for a cardiologist, we are going to look at these collaterals. We are going to look at pulmonary arteries. Pulmonary arteries sometimes we can't make out, so we go to CT. And as we saw, CT can show you how the pulmonary arteries are. Collaterals, again, we used to do angiograms. So we used to go into the cath lab and then you go put a catheter and you can go into it and show the collateral. And many centers still today do an angiogram or a cardiac cath for collaterals. And that is fine. That is also one way of looking at it. Gold standard for collaterals is angiogram. But it's invasive. And sometimes you can't say, is it going over the bronchus? Is it going under the bronchus? So when a surgeon goes in, if we put ourselves in the mind of the surgeon, he opens the chest. He has to take these collaterals and join them up and make a pulmonary artery. He should know, will I find that collateral on top of the bronchus, under the bronchus, behind the bronchus, in front of the bronchus? That 3D visualization of collaterals. In an angiogram, you're going to see it goes left, it goes right. It goes maybe anterior, it goes posterior. But you don't get that three-dimensional look as you can get, for instance, in these images below, which is of a collateral. So I think in situations like pulmonary atresia, where CT helps you is 1 for pulmonary arteries, 2 for collaterals. So in some of these lesions, you're not just going in to look at PA, pulmonary artery. You have to know when you send a patient for a CT scan what you're looking for. If it's a pulmonary atresia, I want to know what are the pulmonary artery anatomy. I want to know how are the collaterals. I just don't want only pulmonary artery. If it's a tetralogy of fellow, I want to know the pulmonary artery anatomy. If you can tell me coronary anatomy, that's good too. So you define what you want to learn from your CT, so it's not kind of a waste of time for the radiologist and a lot of radiation for the patient. This is a little complex, but you can see here, and this I just put this up so that you can see, it's quite easy on CT to diagnose. There's this huge thing sitting in the right lung. It could be an aneurysm, could be a tumor, but we knew this patient had pulmonary atresia. So this was a giant, actually, aneurysm of the collateral itself, what's called a MAPCA aneurysm, which you could see on X-ray and then beautifully defined on the CT scan. Now let's just look at this CT. Anyone can say what this CT is? I will show you what we're looking at and then tell me if you can make the diagnosis. Maybe a little early because we haven't covered all these lesions. Anyone? So there's this structure going like this from left to right, coming around, going under the bronchus, coming back to the left lung. Anyone what this could be? So the beauty of CT is, it's kind of, you see everything that the way we learned in med school, right? So this is your right lung, this is your left lung, right? Unlike an X-ray, where you just see the ribs and you have to understand what's going on. Here you can see it all. So similarly, this is a left pulmonary artery, because starting from the left, it's going to the right, then it's coming back to the left, right? And this is what is called an LPA sling, or a left pulmonary artery sling. You can very clearly see goes to the right, comes back to the left, right? And this on echo you can suspect it, but beautifully seen on CT. So CT is one of those things which is more you can call it pattern recognition. It doesn't need, it needs some anatomy knowledge, but it's more pattern recognition. And so we actually recommend that in today's world, everyone from, the tech who does it, the technicians who do CTs also get very good at diagnosing, or they can become very good at diagnosing. So for instance, we run a very large teleradiology practice. We do about 2,000 CTs a day. And we have our technicians, so they are not radiologists, they are not cardiologists. They are doing the first, preliminary report of it. So it's something that as pediatricians also, when a CT comes, with your patient, just put it up and start looking at it. The pulmonary artery sits right in the middle. The lungs are there. The pulmonary artery is the structure that goes into the lungs. You will get a lot of pattern recognition. So this is obviously a first kind of exploratory class, but it would be good as a pediatrician to start being able to review these. And they're fairly simple once you kind of get the basic structures of, okay, cardiac, but don't focus on intracardiac, focus on pulmonary artery, focus on arch, focus on things going into the lung. So this is an LPA sling where you have the left pulmonary artery, goes over the right main stem, goes behind the trachea and comes back to the left. And while it's going, it compresses that trachea and bronchus. And that's why these babies present with upper airway symptoms. They can have collapse of the lungs. They can have upper airway symptoms. So a baby who's coming back with recurrent upper airway symptoms, we always think, okay, pollution, okay, virus, okay, daycare center picking up, viruses. But if you have a baby going with recurrent upper airway symptoms, in whom, X-rays showing some collapsed areas, think, could this be a pulmonary artery sling? Of course, first send for echo, with maybe a note saying, rule out sling. And then if cardiologist doesn't see a sling or a ring, they may send for a CT or an MRI. Okay. And on this note, any questions on this, on the PA sling? So I know this is a little, a little tougher topic because it's a lot from different diseases. So, bear with me and we'll try and summarize it at the end. So far we've done which situations you look at pulmonary arteries in, where you look at how you look at collaterals. Pulmonary arteries, we talked about small pulmonary arteries, like in tetralogy, big pulmonary arteries with bronchial compression, like TET-absent valve, funny pulmonary arteries with unusual way that they go, then compressing on bronchus, like pulmonary artery slings. Now we move to pulmonary veins. Now, in pulmonary veins, as you know, you can get total anomalous pulmonary venous connections. Now, TAPVC echo is gold standard. You don't need CT. And today, I say this again and again because today I find a lot of, times TAPVC sent for CT. No, TAPVC echo. Echo can diagnose. Based on echo, you can send the patient for surgery. You do not need a CAT scan or an MRI for a standard total anomalous pulmonary vein. Diagnosis of TAPVC, echo. Echo diagnosed, go to operating room. No need for CT scan. But there's some cardiac conditions where CT is useful in pulmonary veins. Anyone? Anything for that? And this is a little more complicated. We're getting into the domain of cardiology, but really in complex heart disease. When you've got, let us say, pulmonary stenosis, very low pulmonary blood flow, what happens? Very little blood is going to the lung. If little blood is going to lung, how can much blood come back to the heart, right? What happens? Right ventricle pumps to lung, pulmonary artery to capillary, capillary to pulmonary vein comes back to left atrium. If very little blood is going to pulmonary artery, very little blood will come back to left atrium. And if very little blood is coming back, echo picks up blood, echo picks up flow. So what is echo going to see? So in complex heart disease with low pulmonary blood flow, you may have a hard time visualizing pulmonary veins. And that is where we use CT. So for instance, pulmonary atresia or these complex single ventricles or heterotaxy. So this whole complex thing. But if it's a standard, if a baby, 10-day baby, blue respiratory distress, X-ray shows small heart, lungs are snow white appearance, you do echo, TAPVC, obstructed, go for surgery. No need for CT. So I would like to send that message out that CT for TAPVC is only for certain conditions. Now look at this CT. Anyone make it? This is a TAPVC. Can you tell me which TAPVC? Just looking at this. And this is hard if this is the first time you're seeing CTs. But look, let's look at this is a vein, right upper, left upper, yes, right lower, left lower, right? They're connecting, all are connecting here. And then this is a vertical vein going down, down, down below the diaphragm, right? So this is your infradiaphragmatic TAPVC. Now, same thing actually is very well seen on echo, but you can see how beautifully a CAT scan or an MRI will show you the whole anatomy. Now look at this one. This is the same thing, but the vein is going upwards to the SVC. So this is your supracardiac. Now look at these CTs. You see this here. There's a narrowing in this area, where you see where the stars are on the right side. So CT can show you also the sites of obstruction. Where is it narrow? Let me get this annotation tool. So you see here, there's obstruction. You see here, as it goes down, there's obstruction. But you don't need CT for this. In a TAPVC, who presents to you with cyanosis, respiratory distress, you know it's an obstructed TAPVC. Whether the obstruction is here or here or here or here, it makes no difference to management. Because if it is an obstructed TAPVC, what is the management? Have we done TAPVC yet? I think we have not. We've covered TAPVC. If it's an obstructed TAPVC, what is the management? What do you do? What is the treatment? We are going to send straight for surgery to relieve the TAPVC. So where it is obstructed is irrelevant. It doesn't matter. So yes, these are beautiful images on CT, but it doesn't help the patient. So in a standard TAPVC, your cardiologist says this is an obstructed TAPVC. That's it. Send for surgery. But in a complex heart disease with low pulmonary blood flow, Cardiologist can't see pulmonary veins very well, and it's going to change management. Certainly, CT or MRI has a role. Hope that's clear. Okay, so we'll move on to that fourth condition, right? We said arch. So we said we use CT to see pulmonary arteries. When we can't see them on echo, we use it for pulmonary veins, we use it for collaterals. And we said we use it for the arch. Now, which arch anomalies is a CT or an MRI useful for? We did, I think, Dr. Suresh, we covered with you coarctation, right? So if you look at simple coarctation, simple means arch, you see this image here, arch, narrowing, arch. Simple coarctation, echo is adequate. No need for CT. And I'm saying no need for CT over and over again because it's important to remember that CT has some radiation. It is recommended that a patient in their lifetime should only get 2 to a maximum of 3 CTs. So it is very important in the pediatric population that we don't overuse CT. We use it only when absolutely indicated. So simple coarctation, echo. Echo, go for surgery. Issues are if it's a very long segment coarct, a very distal coarct which you can't see, or interruption of the arch where you don't know where it's interrupted, how, what you're going to do, and vascular slings as you saw in your LPA sling. So let's look at a couple of diagnoses. Now here, if you looked at this CT, right, you're going to be like, "Ye kya ho raha hai? I don't know what is going on." Ye nahi de, right? You don't. It's. This one needs, a radiologist because you're going to look at this. Now there's something here. There's something here. We are not radiologists. We don't know what is going on, right? Right? Anyone can tell from this what is going on? I certainly can't from this. But if I showed you this, now you tell me the diagnosis. So this is a three-dimensional now. So with the CTs and the MRs today, they do these beautiful three-dimensional imaging. So now what is the diagnosis? This is the same patient with three-dimensional done. Anyone the diagnosis? So this is a double aortic arch. You can see here, let me show you this. This is your left aortic arch. This is your right aortic arch. This is the trachea sitting in the middle. So this is a double aortic arch, which is compressing the trachea. How will this patient present? How would this patient, you think, present? Double aortic arch, left, right, compressing the trachea. Stridor, yes. So a baby who comes to you with stridor, if you first, okay, they come with stridor, you think laryngomalacia. But it's or they come with stridor and you think it's okay, respiratory syncytial virus. But stridor is persisting. You've got to be thinking in your head, could this be a double aortic arch, right? Could this be a sling? Could this be something compressing the trachea? But first thing you do is not CT or MRI. First thing you would do is echo, because even echo can, if you have a good cardiologist and you give them the history that baby has stridor, I want to rule out a ring or a sling. And a good pediatrician will send to the cardiologist like that. Baby has stridor, I want to rule out rings and slings, right? Then now cardiologist better start thinking. So when he does echo, he'll go left, he'll go right, he will look for double arch. But there are some rings and slings that he may not pick up. And so if the cardiologist, he has a little doubt, this is not looking right, that's not looking right, he himself will send either for a CT or an MR. In today's day, I prefer an MR because no radiation. So for most of these lesions we are discussing, if we can do an MR, you can get the same information. So, but you can see how beautifully, and that's why, again, it's important if you're doing a CT or an MRI to do it at a center that can do 3D reconstruction. No point sending for a CT scan to a 2-slice scanner who's going to, give you the images I showed you before. if you're going to send to a place which has a 64 slice scanner and can do 3D reconstructions, because then you are going to get anatomy like this. And this is useful anatomy. This you can look at and say, aha, I know what to do. I'm going to, we're going to send to the surgeon and he's going to cut off that one of the arches and this baby's stridor is going to be relieved. So that is where the discussion between, the cardiologist, the pediatrician, and the radiology center, or whoever the center is doing the scan, is very important. It's, just writing off a CT and telling them to go to any local center, get it done and come back. All we've done is burnt the baby with radiation and not got any information. And the information we want is this. So we need to be demanding that, hey, we want to see a good three-dimensional image in order to make a decision on what to do. So to summarize this, where do we use pre-op? Where do we use? So give me a few lesions based on these topics we discussed, few cardiac lesions where you would be thinking your cardiologist needs to send for a CAT scan or an MRI. Couple of lesions based on what we discussed, just to see everyone was listening. Anyone? So yes, stridor LPA sling would be one. Stridor double aortic arch, right? Yes. So if you're suspecting double aortic arch, slings and rings. Where else? Which other lesions? So for pulmonary arteries, yes, so pulmonary arteries. Dilation only if you're looking for bronchial compression. Or yes, pulmonary artery anatomy. So tetralogy of Fellow, we could use it for pulmonary arteries or collaterals. Pulmonary atresia, we could use it for pulmonary arteries and collaterals. Tet absent valve, we can use it to see if pulmonary arteries are causing bronchial compression. Pulmonary veins and TAPVC in low pulmonary blood flow situations like pulmonary atresia, and complex arch anomalies and slings. So to summarize these, and you can maybe take a picture of this slide, because this is really where, you are using the indications for CT and MRI in congenital heart disease today, not for every lesion that exists. Now, we do use it in post-op cases as well, but I think I don't want to spend time on that because these are, not always, just sometimes if we're confused, we use it in post-op cases. Mostly echo is enough. Now, let's look at the pros and cons of CT. What do you think is the biggest pro of CT versus MRI? What is the biggest advantage of CT versus MRI? Time. Yes, CT is patapat. CT is your McDonald's. MRI is your fancy restaurant where the food will come after 1 hour. So CT is fast. What do you think is the con of CT? What is the disadvantage of CT? Radiation. So these are the 2 points. CT Pro is short exam time. So in pediatrics, what does that mean? You don't have to sedate much, right? The other big advantage of CT is you can see the lungs very well. Like I showed you, right, that bronchial compression, the lungs, all that can be looked at very well. The con really is radiation. The other con is, you can't look at like functional information. Like for instance, what is the volume of right ventricle, so on and so forth. All that is better seen on MRI. Now, radiation risk of CT versus cath lab. See, everybody talks about radiation of CT scan. But I want you to understand that even the cath lab has radiation, which is why when you do an echo on a baby, right, it is best to try and get all the information from echo. Deciding on CT, or just because CT seems easier, we don't just write CT. Just because we don't have CT scanner, we send for cath lab. No, we try to get all the information on CT, on echo. Only if we don't have the information, then we go for CT or cath. Now, what do you think is the radiation risk of a CAT scan versus cath lab? What do you think? Same? You think CT has more radiation, less radiation, same radiation as cath lab? You think more than cath. And this is what most cardiologists also think. So I actually pulled out the data on the millisieverts. You know, what is the actual radiation? So a chest X-ray is zero point 0.1 millisieverts. Okay, so it's hardly any radiation. And it's good to remember these numbers because you can tell your patients also, right? It's zero point 0.1. Pediatric chest CT has 1 to 10 millisieverts. So chest X-ray is zero point 0.1. Pediatric chest CT 1 to 10. Adult chest CT 7 to 15. They are bigger, right? So you're scanning much more. But okay, let us say 10. Let us remember somewhere in the range of 10. And I want you to remember that pediatric chest CT, when you do it, it is very, very important to go to a center where they know that it causes radiation. And what should they do to prevent radiation risk to a child? What should they do in that CT room? What should you ask them? What shields should they have? What shields? They should have a lead shield for what all? You're radiating here. They must have a thyroid shield. They must have an abdominal shield. They must have a groin shield. Very important, yes, genital shield, abdominal shield, thyroid shield, especially thyroid. We forget the thyroid, right? We think of the genitals, but your chest is here. The thyroid gets a lot of radiation, and so very important. And you need a special pediatric thyroid shield. Very important. Anyone who is doing pediatric chest CT, these shields have to be there because you will minimize radiation. To the rest, you don't thyroid, bichara. The thyroid doesn't need radiation, right? You're trying to look at the lungs and you're radiating everything else. So very important to think of shields. The second thing that can be done, and there is a whole paper and literature and protocols on how to minimize radiation. So that is why that range is 1 to 10. So there is what is called conic. So where you just put the beam onto the area that needs to be scanned. And this is the beauty of actually CT scan, that you can minimize. So in our center, when we do pediatric CTs, we minimize our radiation to the child. So we can do it for as low as 1 or 2 millisieverts. And now if you don't minimize and you just put them on the table, you don't put shields, there are all these protocols in the scanner itself. In the latest scanners, like you ask, you need to understand the scan center you are sending your baby to. And are they using these latest protocols that give the lowest beam possible, the lowest radiation possible to get same information? You have to minimize radiation. Now, let's look at cardiac cath. In cardiac cath, you actually do the whole. When you do, you are trying to see arch, but you are seeing lungs. You are on everything. It is about 20 millisieverts. So interestingly, and this is something, obviously, I'm a cardiologist, but cardiologists don't talk about. But cardiac cath has the same radiation risk, if not higher, than a CT scan. So today everybody talks about, radiation from CT. Yes, there is radiation from CT, but you have to minimize that radiation, especially in pediatrics. We don't want to burn them for life. But remember that cardiac cath has a radiation risk as well. And therefore, it is so important. And that is why we are taking the time to, because, you are the gatekeepers. You are the gatekeepers where if someone is just randomly writing for caths or CTs, you have to be the gatekeeper to say, hey, why? What are we looking for here? Do we really need this cath? Let's talk to the surgeon. Can we do it without? So important. For instance, I'll give you an example. Pulmonary atresia VSD. 15-day baby is blue around 85% sat. we can see the pulmonary arteries. We are watching this baby. Baby becomes 3 months. Baby is still 85% sat. So we know collaterals are there. Surgeon says I'll operate when baby is around 6, 9 months. Is there any point doing a CT scan at 3 months? No. We wait till when we are going to. We have to align to when we are going to intervene. And that is the discussion that has to happen from pediatrics to cardiology to surgery, and all three together take that decision, because this is otherwise what happens. We're just otherwise burning those kids, whether in the cath lab or in the CT scan suite. Now the MRI pros, what is the pro of MRI? Would be the con of CT, right? There's no radiation. That's the biggest pro. But, and the other pro, of course, is, that, and we didn't go into that on MR, is we use it for a lot of this right ventricular function, and this whole RV dilation and RV the volumes of right ventricle and so on. So I didn't cover that whole part of MR usage today. But the biggest con in pediatrics is long scanning time. You need breath hold. It's very hard in a 6-month-old, 1-year-old to do an MR. So they have to be in the scanning room for 45 minutes. Then if they're intubated and they're sick, you have to have a nurse in there and an intensivist in there. And that's why in typical congenital heart assessment in smaller babies, it becomes hard to do an MRI. And that's why the CT gets done. And that's why we have to do the CT with a lot of, radiation reduction. So I think I will end with that. If there are any questions, feel free to email me, or we can take it now because it's post time. But thank you very much. I will sign out with that.
Any questions?
I had a quiz, but I think it's too long for now, Amrita. We'll do it next time.
Okay, ma'am.
Okay, thank you all. Okay, 1 second. There's a question. Sinus venosus. Okay. Sinus venosus ASD is not an indication for CT, MR, or cath. Sinus venosus. Can you all hear me?
Yes, ma'am.
Yeah. Sinus venosus ASD. If you have a doubt on echo that, okay, right heart is dilated, but I'm not seeing ASD, right? If there is a doubt on echo, then this next investigation that should be done is a transesophageal echo, where you put the echo probe from here, and then, because see, the RV lies most anterior, then you have the LV. Behind it lies the right atrium, left atrium, right? So the atria are most posterior. So when you put a transesophageal echo, you are putting an echo probe through the mouth behind the esophagus, but you're getting a beautiful look at the interatrial septum. And you can easily diagnose a sinus venosus. So in an older patient with, let's say not good windows, you're suspecting sinus venosus, or then the next investigation of choice is a transesophageal echo. I agree with you. What is happening in today's world is they're giving sent for CT, but that is not an indication for CT. It's not an indication for the cath lab. The only time you'll do a cath lab is if it's an older patient who you want to also assess the lung pressures. You want to see if they have pulmonary hypertension. Okay, we may cath them, no problem. But you, 8-year-old, you're suspecting sinus venosus, they need to go for transesophageal echo. And that is why, I wanted you to understand indications of CT. Because what is happening in today's world is we have a doubt on echo, we send for CT. You have a doubt on echo, you do a different kind of echo. If you can't do a TEE, okay, no problem. There's someone else who will do a TEE. There is enough, enough expertise in India today that you can do a transesophageal echo. So very important. Of course you can diagnose, let me put it this way. all of these lesions can be diagnosed on CT. Sinus venosus, ASD, VSD, you can diagnose on CT. You can even diagnose aortic stenosis on MRI. You can diagnose all these lesions on CT, MRI. But should we be doing a CT for those lesions? Because there is that risk of radiation. Echo has no radiation. Transesophageal echo has no radiation. And that is why I truly believe it is important to empower you all. Because if your cardiologist is saying I'm suspecting sinus venosus, let's get a CT, you ask, can we please do a transesophageal echo? Because that will show you the sinus venosus ASD. Yes, CT will show you, but remember the 1 to 10 millisieverts. And so before, now you do a transesophageal and you're still confused, right heart is dilated, there's no sinus venosus. Okay, and you're looking for other things, something weird and wonderful. Once in a while, you're forgiven. But in general, and maybe we should, as the year progresses, and that's why I would really, we have really planned this program with Hridayam that it goes, A, B, C, D, E. So as the year goes on, all this is going to come together for you. So as the year progresses, we go over, okay, this lesion can't diagnose, what test next? This lesion, what treatment? So that you are empowered when a cardiologist or cardiac surgeon is saying something to at least say, hey, you know what, let me get an opinion from a cardiologist who maybe, if your cardiologist says, no, we have to do CT, say, okay, let me find a cardiologist who'll do a TEE. Let me throw in a concession here. If you are in a place where your cardiologist says, look, I can't do a TEE, you want to do another test and you can't do TEE, do the MRI. That I'm okay with because there's no radiation. So be careful with what you're picking. So you're saying I can't do TEE here, or baby's too small for TEE. I still want another test. Then at least go for MRI. Don't burn this baby. Don't radiate it for a sinus venosus ASD. Sinus venosus ASD for a baby, we should be able to pick up on echo. The only ones, yes, some older, nowadays you have a lot of big kids with poor echo windows. That's where TE comes in. You don't have it, at least think and send, okay, MRI, but frankly, in pediatric population, you ask me a 1-year-old, 2-year-old, 4-year-old, 5-year-old, basic transthoracic good echo is enough for sinus venosus. Okay, so I shall end with that. Adios, everyone, and see you again soon.
Thank you, ma'am. Thank you for
Thank you, Amrita.
Thank you all the participants. And the next class will be on 8th, and that will be the continuation of normal ECG by Dr. Sejal. Thank you all.
Thank you.
അമ്മ ഹൃദ്യം ഹോസ്റ്റ് ആണ് അമ്മയാണോ ഹൃദ്യം